word carries more fear than the word cancer. But hope provides a confidence in a potential to heal tomorrow. I think it's time that we change our approach. Change our approach that restores us to our history, that restores us to our background of what we are as physicians and doctors. Let's focus on healing, but let's do so by promoting a foundation that's guided in hope. A confidence in tomorrow, a confidence in your healing for tomorrow. That's what we want to achieve through a natural, holistic, integrative cancer treatment approach. Now, to achieve that, we have to understand what it means to guide treatment through research, through statistics. Because after all, science, medicine, which is a part of science, is a blend of art and science, but science guards and drives the artful distribution of the art of medicine. So it's science and art together. So when you look at what we're doing in science, what it's about asking questions. Healing is great, but teaching people how to heal themselves is what we should really be focused on. Your healing journey begins today.
Hey.
Here he is.
Hey,
Happy
how's it going?
birthday.
Oh, thank you.
Happy birthday.
Thank you.
Today's going to be a good day for both of us.
Thank you. How are you doing?
I'm doing great. I'm doing great.
Good to see you. So
Ready
good.
to
Good,
get
yeah.
after it again.
Yeah, got to work on this under this eye. Of course, wanting to be problematic, but
Yeah.
we're going to work on it. So just obviously just making adjustments to the medications to try to get more effect. So yeah. So,
Okay. And then hopefully not. I mean, it might swell up and everything like they did before.
It may swell some, yeah, but
Maybe not as much
hopefully
as
not
that.
too bad. Yeah,
Yeah.
hopefully not too bad.
Okay.
So yeah, we'll see. It does what it does. That's hard to
Yeah.
it's hard to control it, but we'll see. Hopefully it won't be too bad.
You think you'll look here too? Maybe it looks
I'm
like on
gonna look and see.
Yeah, the ultrasound
Yeah,
says there's something.
yeah. I'll see how it looks under ultrasound. I'll
Okay.
try to get at least kind of laced all through there.
Yeah. Okay.
yeah.
Sounds
So,
good.
all right, well good. Well good.
It's gonna be a lucky day for both of us.
Yeah, it's a good day. It's my birthday, so
I
it's a
know,
good day.
I know.
It's a lucky day.
Hey, Jason, so we're up here, on the floor here at Williams Cancer Institute, at top floor of the hospital here. Got a case here today, patient with B-cell lymphoma of the face. Of course, her before and after pictures are highlighted on the website. Check it out, williamscancerinstitute.com. But as you go through the journey of cancer, there's ups and downs, and even in this innovative approach of healing, you can still have those valleys, and we have to go back in and activate the immune system. So that's why she's here today. So if you could give us a quick rundown, what are we seeing, and what are we going to do for her today?
Yeah. So her case is challenging just because we're dealing with the B-cell lymphoma. So we deal a lot with all the regular solid cancers, which are not immune cells, but this is a cancer that is immune cells, and so some of your typical immunotherapies are not appropriate because they could stimulate those immune cells. So then it takes some of our weapons away, which makes it a little harder. But then there are certain immunotherapies that are still appropriate. And a lot of it, again, is you hit this, you knock it down, you get the immune system to see it, and the immune system hopefully finishes the job. But sometimes the cancer gets around it and then starts growing again, then you got to re-stimulate and keep doing it. The key is persistence. I mean, you keep hitting it, you keep stimulating the immune system again, and you eventually should get there. I mean, I don't think there's any cancer that we can't get this to work in. It's just a matter of, doing it enough.
And that's just the journey. People talk about vacation. It's I want to get there, right?
Yeah.
But the process of treatment, and that's what she highlighted before, was that the process of treatment allows her to live today.
Well, that's a nice thing. At least, these procedures are, minimally invasive, so recovery is very easy. So you can go and treat the patient and they live their life. So it's just like a little minor speed bump here and there, but they keep going. And so that's the beauty of it. If this was much like other treatments that are much more harsh on the patient, that would be a difficult process.
Now, one unique thing about her case today is that because of the proximity of the tumor right there by the right eye,
Yeah.
we're not going to be able to use the intratumoral ablation. So it's just going to all be intratumoral injectables, right?
Yeah, I mean, technically, could we? We could, but I don't know. In her case, do we need to? I think we don't need to, but and we'll judge and see. I mean, we think that this combination we've got, we'll do it. And like I told her, she asked is this going to be my last one? It's it's always possible. I mean, for some patients, the first treatment is all they need.
Right.
That's obviously what we really want. But there's others that take 2, 3, 4. I mean, occasionally it's somebody like her where much more extensive. But typically for most patients, usually 3 to 6 would be kind of average.
We're really touching on two broad kind of hallmarks of cancer, if you will, the immunotherapy aspect and then the metabolic aspect.
Yeah.
And so we're targeting in this procedure for her today, the oncometabolic. So we're going to be targeting actually how how cancer takes advantage metabolically of the sugar. Everybody knows the Warburg effect, which is anaerobic glycolysis. It's going to be aerobic glycolysis, but we're going to be coupling those therapeutic approaches with the immunotherapy.
Yeah.
And that's a unique aspect here.
It's very unique. I mean, so because it's funny because everybody has their little camp, right? You have these metabolic people, and they're like cancer is metabolic disease, and that's only it. And then then you have the people that, well, it's immune disease, and that's it. But it's both,
right?
And there's an interplay because the metabolics create certain immune suppressing substances, and so I think the fact that we can try to knock it all down. So I mean, we try to knock out the metabolism. I mean, it's just shutting it all down. It's like imagine you're going in a war, and you go in, you cut their water, you cut their electricity, and then now you then bomb them. I mean, that's like
you cut their food supply, and
cut
so
their
they
food
just
supply,
can't feed.
exactly, yeah. And then now they're just completely vulnerable.
Right.
I mean, they can't use their cell phones. They can't do anything, and you totally disrupted them. And then you hit them with the immunotherapies coming on top of that. So now the immune system's going to want to come in, and I think this is the best way. I mean, this is what's going to be the ultimate treatment for cancer.
We need to do more, but yeah.
Hey,
good
Dr.
to see you. How are you doing?
Good. How are you? We meet in person.
Good to see you. I saw you on the schedule.
Yeah, I know.
So
I
it's
heard you're down
awesome.
here.
Yeah. So very good. How are you doing?
I'm ready for
ready?
something that get in there and kill it.
Dr. Williams and Eduardo and I are really excited about that combo.
Okay.
The Dawn 3BP,
Yeah.
and of course coupling it with other things. It's super exciting because now you're not just going after it, with a chemo and an immunoactivating agent.
Yeah.
You're actually now metabolically interfering.
Yeah, I was reading.
So
up on
it's multi-pronged,
Mm-hmm.
and so super excited about it because obviously the resistance of this
Yeah.
and the proximity to it, hopefully this won't create near as much of an issue there locally with that Dawn and 3BP.
Okay, like with the info.
Yeah, because I thought Eduardo was doing a great job talking to you
Yeah,
about the chemo. You got to be really careful about all
Yeah,
that. But it's the combination. And what I actually went back through and looked at all the treatments that you had and
Yes,
correlated them with response. And so just trying to, and I sent those to Dr. Williams to take a look at because trying to, say, well, okay, just go back and look at the data. What does the data show about treatment and response? Treatment and response to get a better prediction of not just is it chemo, is it immunotherapy, but what is a combination of the therapeutics together that seem to be responding well. So
that's what Dr. Bentley had seen too. Like, every time that we had such a big move in the needle, he was saying, of the tumor, it was like coupled with some chemotherapy,
Yeah, and we'll I'll see what Dr. Williams wants to do, as Eduardo was correctly saying, and because the tumor and the volume is going to limit how much can be and what can be injected. But I could tell you the Dawn and the 3BP super excited about
Yeah.
that
Yeah.
combination. Super excited about
Okay.
it. So, and in the future, even methylene blue to be a part of that as well, because these are very critical. Again, we tend to get caught up in chemo, and I know, we talked about that because we don't like chemo.
No.
But it hits the tumor.
Yeah.
Okay, and that's why I said let's talk about all aspects of what chemo, full dose, low dose, etc., about what needs to be there because it destroys the cancer cells. So maybe we just need a little bit more of that destruction in conjunction with the ablation.
Right, yeah.
Then the immunotherapy, now the metabolic therapies. Now it's a sweet 1, 2, 3 punch.
Right, yeah.
So, we're hoping that now what we have to be conscious of, obviously, for you is the proximity to that eye.
Yeah, yeah.
And that's a little bit of a challenge, but you've seen they navigate it very well.
Yeah.
So, yeah.
I'm excited.
Yeah.
Like slightly nervous, but I'm excited.
Oh, you're gonna do great.
Yeah.
And really enjoy communicating with Dr. Bentley as well. Let me ask you this, because you know this firsthand. When people are typically diagnosed with cancer, they lose their humanity. Do you feel like you've retained who you are as Christine, who you are as a wife, who you are as a mother, in this process?
Yeah, I feel like I have because of the way that we're treating this. Like I know when I first started off and, I went to conventional oncology, it felt very like they didn't really know me. They don't really, here's your binder, here's all the things that are going to go wrong with you. And, and they didn't really care. But I think because, the Lord has led me to the healthcare professionals, I don't want to cry about it, but I'm so grateful,
Yeah.
that
Here
and Dr. Bentley, yeah.
No, he's great. He is a.
So I don't feel like a number. I feel like I am treated like somebody's wife, somebody's daughter, like that I do matter,
Well, you're actually God's daughter, so we got to take care of you that way.
You better.
That's right. That's right. Because we have to answer for that. We have to answer for that.
Right.
We have to answer for that.
And I think his wrath is probably a little stronger than mine, although mine is up there.
Yeah, and we could get the brunt of that. We could get the brunt. Yes, your wrath is right there. Yeah.
Not wrath, just passion.
Yeah, and that's great.
Concern,
and that's great. And that's all great. But that's part of humanity.
Yeah.
That's part of being human. Okay. And
I've
that's
really
all.
been able to do all the things that I love that are super life-giving to me. We have a granddaughter that's getting married, and flowers and decorating.
This is the future of what treating cancer looks like. There's not a question about that. Now, are you good on the AGE 777? You don't need any more supply on that?
Yeah, I think Eduardo's going to
Okay.
get me some more. I
Okay,
think they
good.
have like 5.
Because we have some down here
Yeah.
now, so I'm just making sure on that.
Yeah, and I renewed my Actemra and Kineret and stuff all came before.
Good.
I love
Good. All right, so I'm gonna let you get back to getting ready. Okay. All right.
All right, we'll see you.
All right.
I'm excited. I'm excited for some healing. I'm trusting in God.
The question is, what's the sort of advantage of adding, metabolic targeting agents to the immunotherapy? And the situation is that the immune system obviously very powerful in attacking the cancer, but the immune system is biologic in cells, and so is the cancer, right? And so the immune system can be attacking the cancer, and the cancer can be trying to match it, growing, right? And so the immune system is then like going back and forth. It's killing cancer, but the cancer's growing, and so then you get this sort of where it's like static, right? But if you can do stuff to inhibit the cancer's growth, now, obviously there's several ways to do this. I mean, you can use chemotherapies, but then chemotherapies might negatively impact the immune system. But the other idea is that, with us sort of inhibiting the metabolism of the cancer, well, now the cancer can't, grow as well, and that weakens it. So I think as I was telling Dr. Goodyear yesterday, that it's like the idea, like if you're going into a war, and you go and you cut off the electricity, you cut off the water, you cut off the food supply, and then you're attacking. So you're attacking a weaker target, and that just makes it a lot easier for the immune system. And so we think that this will, help with some of those cases where the immune system might struggle. You don't necessarily need it on all patients, and I think with patients with less tumor burden, probably not necessary. But definitely patients that have a little more and need some reduction, this is a great thing to help. Oh, yeah. Yeah. Yeah.
Using a small needle, a 22 gauge needle, so it's a pretty small needle, and going to use that to be able to access the tumor. What we were looking at there with the ultrasound was the actual tumor, and so what we'll do is here, as the procedure starts, you'll be able to see actually, okay, not just one, but multiple immunotherapeutics to actually destroy the cancer but activate the immune system locally and allow that systemically to then move to migrate throughout the body. Again, a time and spatial treatment strategy. Local, acute, systemic, sustained. That's what the abscopal effect, and that's what we do. There's a real possibility that the future of cancer care is going to have very little surgery, chemo, and radiation.
It's going to be, we're going to eliminate that completely. How you doing?
Yeah.
Good.
Good.
How are you?
Good, good.
What you guys do?
Yeah, so we went and injected, put the medications that we needed to try to kill this thing here, but it looked at, you're getting some swelling. Hopefully it will stay mild.
Okay.
So yeah, so we put a couple of agents, one called 3-bromopruvate, which blocks the glucose metabolism, the other Don, which blocks the glutamine metabolism.
Okay.
Yeah, then we did immunotherapy wise, we did OX40 and CPG and CTLA4 and a PD1. It's kind of a good base we know for this cancer type, but yeah. Because there's other agents that we use, but those become, more questionable because your cancer can have receptors for those that actually can stimulate it. So we have to be cautious in what we use. It's different than what we would do in a case for like a regular solid cancer, right? I mean, and because your tissue of origin is technically the immune cells,
Right.
and then we're using immunotherapy. So we have to be cautious because some immunotherapies stimulate immune cells and they could stimulate your immune cells. And so those are ones we don't want to use. We want to use stuff that's going to more direct the other immune cells against the immune cells that are cancerous. And so that's why we do what we do.
Quickly, do you think I'll see some reduction in?
Well, these metabolic agents kill pretty quickly within hours.
Yeah.
But so they get tumor killing, but you get simultaneously because the tumor's dead, it'll swell. So and then it'll shrink. So the shrinkage can be fast, but probably going to take at least days. All right. So
Okay.
yeah.
Do you think I'll have to come for another one?
I don't know. I think we have to see what this does. I mean, every treatment has the potential to just knock it out, right? I mean, so I think we have to see if this, is this the one that does it? It could be. So right. So yeah, I think we'll know. We'll I think over the next few weeks we'll get a good idea, and do we need to hit it again or not? Yeah.
So
I think I'd like to see an ultrasound maybe like three weeks.
yeah, that's what I was going to say. So 3 to 4 weeks on ultrasound. Okay.
Yeah. So I can look and see what the tissue's looking like. I can see if there's still a viable cancer. Because if that's the case, and let's say we've knocked it down, but there's still little pieces that we need to hit those. We need to just get them to go away. Yeah.
Cool.
So yeah.
Cool.
All right.
Awesome.
Very good. You're welcome. Thank you. I appreciate it. Thank you. It's a good way to celebrate birthday. Always killing cancer is my favorite thing to do is kill cancer. So, might as well do it on my birthday. seems appropriate. I do it on Christmas Day too.
Yeah.
All right. Very good.
Okay.
We'll get you up and out of here shortly.
A physician must be one that first does no harm. One that is open to change as new evidence, new data is published. Understand the statement that the science is settled is by nature unscientific. Science is never settled. It constantly evolves with new understanding. It doesn't mean we were wrong to begin. It just means we've discovered and we've been enlightened to new ideas that basically adjust our vision of the past. A physician is not one that's identified attached to a system, a hospital, a government, or a regulatory body. A physician is one who's committed to the patient and the patient alone. Follow the data to be the best patient advocate. That's what a physician is. That's what a good physician is. Hope. Hope it forward.